Hello everyone, I'm Dr. Divya, second year radiodiagnosis resident at AIMS Baby Nagar, and I'm here to show you all an interesting case that we had seen during our ultrasound rotation. This was a case of a 36-year-old female who presented to the plastic surgery OPD with complaints of left breast enlargement since 18 years. This left breast enlargement was not associated with any pain, ulceration, or skin changes. Previous history, the patient had similar complaints in the past for which she had underwent reduction mammoplasty in 2005. However, the patient reports that the size of the left breast started increasing again after about 2 years after the reduction mammoplasty. The patient did not have any relevant documents pertaining to this previous surgery, and so we did not have the HP of this surgery available. And on physical examination, the left breast was soft and there was a non-tender mass which was involving the whole of the left breast. And patient is also a known case of primary infertility. So then this patient was referred to our department for ultrasonography of the bilateral breast and the bilateral axillae. So ultrasound of the left breast was performed using the linear probe, which revealed that the left breast was diffusely enlarged with multiple discrete, confluent, anechoic, multiseptated cystic spaces, which were seen involving all the quadrants of the left breast. There was no evidence of any internal vascularity within these cystic spaces, and there was no evidence of ductal extension or solid components within these cystic spaces. And there was also very minimal amount of normal breast parenchyma which was seen interspersed between the cystic spaces. These cystic spaces were also seen extending up to the axilla. And the right breast, however, was totally normal and there was no evidence of focal lesions within the right breast. So based on the imaging features of the left breast, these are the differential diagnoses that we had considered. The first is the lymphatic malformation of the left breast, considering the multiple discrete anechoic multiseptated cystic spaces with no internal vascularity. The second differential diagnosis is the fibrocystic disease. However, all the lesions were seen within the left breast and the right breast was completely normal, which is unlikely for fibrocystic disease. On imaging features, hematoma and abscess can also be considered. However, clinically, the patient did not have any previous history of trauma and the patient does not report of any pain or fever. So the differential diagnosis of hematoma and abscess are also unlikely. So based on these differential diagnosis of lymphatic malformation of the left breast, to confirm our findings, we had referred the patient for dynamic contrast MRI of the bilateral breast for further evaluation. So these are the representative images of the bilateral breasts, of the T2 stir coronal images and as well as the T1 axial images. So we can see that the left breast was diffusely enlarged with multiple well-defined lobulated T2 stir hyperintense and T1 hypointense cystic lesions, which were seen diffusely involving the entire of the left breast parenchyma, and there were multiple internal septations within. And anteriorly, the cystic spaces are reaching up to the skin with no obvious evidence of infiltration. And posteriorly, there is maintained fat planes with the pectoralis major muscles as well. Posterolaterally, the lesion is also seen extending up to the axillae as well. On DWI, we saw that there were few areas of diffusion restriction and there was a mean ADC of 1.5. This is the phase 1 of the dynamic contrast images, and this is phase 19, the last phase of the dynamic contrast. And we can also see that there was not much enhancement which was seen. So based on these features of multiple well-defined T2 hyperintense and T1 hypointense cystic lesions which are diffusely involving the left breast parenchyma, we had given the diagnosis of the diffuse lymphatic malformation involving the left breast. So coming to the discussion part of cystic lymphangioma, that is a variant of diffuse lymphatic malformation. Cystic lymphangioma are rare lymphatic malformations which result from retarded development or obstruction of primordial lymphatic channels. And these are said to result from sequestration of either lymphatic sacs, or they occur because the lymph spaces, they fail to connect or communicate with the main central lymphatic channels, and they tend to occur along the lymphatic drainage routes. And cystic lymphangiomas, they consist of well-defined cyst-like spaces which are lined by endothelial cells, and they're filled with clear lymph fluid. And generally, localized cystic lymphangiomas of the breast, they can occur in this upper outer quadrant, the tail of Spence, or in the subareolar space. However, in our case, the lymphangioma was diffusely involving the left breast and seen extending up till the axilla. And lymphangiomas, they are always benign and they have never been known to harbor any malignancy. And cytological studies of the fluid, when they are aspirated, they are found that lymphangiomas show scanty cells, predominantly of lymphoid origin. And surgery is the mainstay treatment, and post-op complications can include infection, hemorrhage, and fistula formation. On HP, grossly, these cystic hygromas, these are multilobulated multicystic, and they have cysts of varying sizes with intervening septae. And microscopically, the cyst walls are lined by a single layer of flattened epithelium. So this was the interesting case of diffuse left breast lymphatic malformation that we had seen in our ultrasound posting. Hope you all enjoyed seeing this case and learned something new. So thank you everyone. Stay tuned for the next video.